We'll start our 7th session, title of medication. I would like to welcome our two chairpersons, Dr. Muna Sharifi and Dr. Hind Mansour Abdulrahman. Dr. Muna Sharifi is a graduate from Jordan Zaytuna University in Pharmacy. She is currently a pharmacist in Andalus Al Raqi Clinic. Dr. Hind Mansour Abdulrahman, she is a pediatric specialist metabolic team at Jahra Hospital. She has a PhD degree in pediatrics. She is currently a lecturer in pediatric at Zagzag University in Egypt.
Assalamu alaikum wa rahmatullah. With pleasure, I want to welcome Dr. Nawal Makseed. Dr. Nawal Makseed is pediatric metabolic consultant. She is a fellow of American Board of Pediatric and a fellow of Royal College of Physicians, Surgeon of Canada. Has completed 3 years fellowship in clinical biochemical genetics at University of British Columbia to become a fellow of American Board of Medical Genetics and fellow of Canadian College of Medical Genetics as well. Today, Dr. Nawal will talk about medication for metabolic cases. Welcome, Dr. Nawal.
Assalamu alaikum. Good morning, everybody. It's my pleasure to be here today, although Dr. Fahad seems upset because I wasn't here yesterday. But he promised me that he's going to give me extra 5 minutes because he gave me the toughest one. So I'm going to talk about metabolic medications. It doesn't mean that what I'm going to present is all the metabolic medications that we have. So just bear with me. So I'm going to cover the emergency hyperammonemia medications, maintenance hyperammonemia medications, amino acidopathies management, and enzyme replacement therapy. But others I will not have time to talk about, okay? Many of you has attended a lot of my lectures talking about inborn error of metabolism, and inborn error of metabolism has 3 main presentations, either an intoxication form, energy insufficiency, or problems making and breaking complex molecules. And in terms of intoxication, the most common that we see is urea cycle disorder or organic acidemias that present with hyperammonemia medication. Hyperammonemia presentation. Why it is important to recognize hyperammonemia early and treat it early? Because hyperammonemia, if left untreated or unrecognized early, it can lead to minimally developmental delay to death. And in between, there could be a catastrophic final outcome. Currently, we're managing a patient in neonatal ICU at Jahra who presented at day 3 with sepsis, and his ammonia is up to 4,000. To save such brain, it would be really difficult. You need a miracle to save such a brain. So, why is it important to recognize and treat early? Because there is clear correlation between the duration of coma and the outcome or the IQ. So the longer the duration of coma, the lower is the IQ after you save this baby from his hyperammonemic crisis. The best modality to treat patients with hyperammonemia is to do dialysis. As you can see, unfortunately, I can't use the because it's an LLD, I can't use the pointer. You can see the PD on top, which is peritoneal dialysis. So this is the least effective. And now it's rarely used anywhere in the world because it takes longer time to clear hyperammonemia. The best modality is the CVVH. But unfortunately, until today, we don't have anybody from nephrology section that is willing to dialyze such patient because this is the fastest and easiest way. That's why we rely on acute management, emergency medications to treat such patients. Okay. So this is the urea cycle. Urea cycle starts with the formation of ammonia from glutamine and glycine, and with the formation of a very important compound called N-acetyl glutamate that requires acetyl-CoA that's released from fatty acid oxidation. And in the presence of NAG, N-acetyl glutamate, and the presence of CPS1, we form carbamyl phosphate, which binds with ornithine to form citrulline, and citrulline leaves the mitochondria through a transporter to bind aspartate and form arginosuccinic acid. And with a lyase enzyme, you release arginine, and with an arginase enzyme, you release ammonia and you form ornithine, and hence the urea cycle goes to release to and excrete ammonia as urea. However, if you have organic acidemia, which I represent here as OI, organic acidemia inhibits the formation of NAG and acetyl glutamate formation. In the old days, we used to use, beside the dialysis, if it's available, we use sodium benzoate, which binds with glycine and converts it to hippuric acid, which is excreted in the urine. And with the advancement of the medication of inborn error metabolism, sodium phenylbutyrate, which is known as ammonabs, converted inside the system to phenyl acetate. It binds with the glutamine and converted to phenyl acetoglutamate, which is again excreted in the urine. Why is it important to bind glutamine? Because glutamine, it's high, very elevated in the brain, and it causes astrocytes, and this is what leads to cerebral edema in hyperammonemia patients. And this type of edema does not respond to mannitol or corticosteroids, so use of mannitol and corticosteroids is useless in patients with hyperammonemic encephalopathy. So, before we had a new medication, we used to give ammonabs orally because we don't have phenyl acetate IV, and we give sodium benzoate. But this gives the patient a huge load of sodium because they are sodium-based compounds. That's why a special medication called ammonol, which is a combination of those two drugs, sodium benzoate and phenyl acetate in one medication to reduce the load of sodium on the baby. And combining those medications, this will lead to the release or the detoxification and remove 3 nitrogens with 1 molecule of this compound. As we said, organic acidemia, the accumulation of organic acid inhibits the formation of an acetyl glutamate, and fatty acid oxidation also. If there is a defect in fatty acid oxidation, there is not much acetyl-CoA which is required for the formation of an acetyl glutamate. So thus, this will block urea cycle from going on, and it's an early step in the urea cycle. In organic acidemia, we see a lot of patients, especially the propionics and methylmalonics, and they can present with ammonia of more than 1,500. But I haven't seen a single case of fatty acid oxidation defect in Kuwait that would present with hyperammonemia. In the literature, they say it causes hyperammonemia. Physiologically, it should cause hyperammonemia, but we haven't seen it. So the use of a medication called carbaglu, which is an analog of an acetyl glutamate, and this has been used efficiently in patients with organic acidemia or NAGS deficiency or CPS1 deficiency. As a result of a block in the urea cycle, there is a deficiency of arginine, and arginine supplementation is a must to carry on with the cycle and make this urea cycle moves forward. This is the ammonol. Hemodialysis, if you read the literature and the recommendation, hemodialysis is indicated in ammonia above 500 in pediatric patients. But being in Kuwait, where each center, we have a pediatric ward in each general hospital, so it's really hard to get a dialysis run up as quickly as needed. And also in adult patient, the current recommendation, if ammonia is above 200, patient needs dialysis. However, with the existence of such effective medication, the use of dialysis has been reduced dramatically. We made sure that ammonol is available in each single neonatal and pediatric ICU all over Kuwait, so that whenever it's needed, it's available and it can be used and given to the patient within less than half an hour because it's available in stock inside pediatric ICU. Okay. So what about the long-term hyperammonemia pharmacotherapy? We use the ammonia scavenger, mainly sodium benzoate or sodium phenylbutyrate, which is known as ammonabs. We have to supplement arginine and citrulline, and it depends on where is the defect within the urea cycle. And the most important one in organic acidemia is the use of carbamyl glutamate, which is carbaglu. We'll discuss in details. Sodium phenylbutyrate have been found since the 1990s that it has reduced the risk of hyperammonemic episodes more efficiently than sodium benzoate because it removes 2 nitrogens compared to 1 nitrogen removed only by sodium benzoate. In USA, all patients are given sodium phenylbutyrate, while in Europe, sodium benzoate is used as the first choice. I think it's related to budget issue, not related to the effectiveness, because sodium phenylbutyrate is far more effective in the management of a long-term management of patients with hyperammonemia, either especially due to urea cycle. Some patients may need sodium benzoate and sodium phenylbutyrate. These are in the severe cases of urea cycle, but always remember that they are at risk of high load of sodium. However, with the use of sodium phenylbutyrate, compliance has been really an issue because sodium phenylbutyrate comes in a powder form, very difficult to dissolve, and if you put it in a milk, it usually stays around in the bottle. So you have to make sure and teach the mother that she has to wash the bottle and feed the child the rest of the powder that's hanging on the bottle. So companies had tried more and more to make the hyperammonemia medication, long-term medication, more palatable to increase the compliance. And there is a new form called Ravicti, which is a liquid oil glycerol phenylbutyrate, and which is the most comprehensively documented to, as an ammonia scavenger in hyperammonemia medication, as an hyperammonemia medication in UCD. It leads to improved adherence in ammonia control, and because of its unique pharmacokinetic profile and the convenient low volume formulation, this had led to the potential strict treatment and targets for patient outcome. And this has led to less payment because you're going to use more amount if you use sodium phenylbutyrate compared to the Ravicti. Physicians had seen that the patients were more stable and they have improved care and control of hyperammonemia, and families, they were less worried and their life with urea cycle has been less burdensome. This is just to tell you or show you what is the difference between the ammonia control. These are ammonia measured 4 hourly in patients taking sodium phenylbutyrate compared to Ravicti, and there is a significant difference between the ammonia level between the two medications. Sorry. And this tells you, it compares the volume of the use of Ravicti compared to sodium phenylbutyrate pills. It occurs at pills, but this is for adults mainly. For pediatric patients, we are mainly using the powder form. So imagine taking, as an adult, 40 pills compared to 5.8 ml 3 times a day, and it's tasteless, odorless product. And the clinical studies on using Ravicti, it showed that 25 patients had a total of 45 crises over a year when they were on sodium phenylbutyrate, compared to 16 patients who had 23 crises over a year when they used the glycerol phenylbutyrate. So, and when they did a survey on patients who have been in clinical trials, more than 90% of families and patients elected to remain on Ravicti as a long-term therapy. When it comes to Carbaglu, it's a carglumic acid, which is an analog, as I said, of an acetyl glutamate. It's used in NAX deficiency, CPS1, and urea cycle disorder, and it is the only specific treatment for hyperammonemia and acute decompensation episode of organic acidemia. But it's usually used in combination with other ammonia scavenger. This is from an old study. Once Carbaglu has been released and has been approved within the European community, it showed you that at 10 hours, when Carbaglu, which is indicated as CG, within 6 hours, ammonia from 600 dropped down to 100. So this is a very efficient way of reducing ammonia in patients with organic acidemia. And this is a study to compare using carglumic acid alone and ammonia scavenger alone, or carglumic acid and ammonia scavenger combined in patients with organic acidemia. And you can see that using combination within the first hours, 28% drop in ammonia, and within 72 hours, it was up to 76%. So it was a huge drop. But if you compare carglumic acid alone and ammonia scavenger alone, 17% drop within in the group that has been given carglumic acid compared to 2% when we used only the ammonia scavenger. So combination of both has been really effective in managing hyperammonemia patient with organic acidemia. This is a special, study that was done. Maybe the number of patients is 8, but it's a very efficient study done by Dr. Bellina from Italy, and this was presented at the SSIEM. This shows you 4 propionics and 4 methylmalonics, and this tells you the difference between the blue line is ammonia level before giving them chronic dose or a maintenance dose of carglumic acid compared to the red bars. So there was a huge drop in the ammonia level on the long-term follow-up of these patients with propionic and methylmalonic acidemia. Not only this, he had shown that there is a 2 to 4-fold decrease in the number of decompensation among those 8 patients. And I'm sure all of you as pediatricians have come across an organic acidemia patient who comes in a decompensation. They come really, really sick. They required less episode requiring hospital admission because emergency plan can be implemented at home, and with the presence of carbaglu, we just instruct the mother to give an extra dose of carbaglu, and the decompensation can be terminated at home. There was 20 to 50% increase in protein intake with a weight gain of ranging from 0.5 to 6.5. There was an improvement in attention, school activity, appetite, and reduced need for G-tube insertion. And the recommended dose, but this is not, not a studied dose, 30 to 50 milligram per kilo per day. In fact, I used carbaglu. I was the first maybe in the world to use carbaglu as a maintenance dose, and patients has done it dramatically. But this is the only study that has been discussed in details in the SSIEM. Amino acidopathies, I start with hyperphenylalaninemia or PKU because this is the first disease to be screened in 1960s. And since we started the newborn screening program, which was launched about 18 months ago, we've been diagnosing more patients. And since hyperphenylalaninemia and PKU has been diagnosed and proved that dietary management had a good outcome, parents and patients had been compliant with the diet. But believe me, it's a very harsh diet, especially in poor countries where there is not much of facilities to provide them with a low protein diet. As you may know that PKU, it can be caused by either a deficiency of an enzyme called phenylalanine hydroxylase or a deficiency of its cofactor, which is a BH4. BH4 is a compound that we form in our body. We require about 5 enzymes to make BH4 in our system. So anybody or any baby born with hyperphenylalaninemia, he has to go through a specific protocol. What we do is we measure pterins in urine, and we do a DHPR, and this is related to the BH4 synthesis pathway, and we do also BH4 loading test. And based on the results, in the old days, either we diagnose the patient as BH4 deficient patients because they do respond to the BH4 loading test, or as classical PKU. However, studies over years had shown that some patients who has been proved to have PKU due to an enzyme deficiency, phenylalanine hydroxylase deficiency, and has been documented with a mutation analysis, they have been BH4 responsive, which means that if you give BH4, the level of phenylalanine drops when you give them, and they need less protein restriction. That's why the BH4 loading test has been modified and remodified and remodified, and there are 2 protocols, one from USA and one from the European. And what I follow is the European one because it's an easier and a shorter form of BH4 loading test. So when the patient is diagnosed, we give them 20 milligram per kilo per day, and this is a test done over 4 days, and we take a serial measurements of phenylalanine and see whether the patient is BH4 responder or not. Initially, the definition of BH4 responsiveness for PKU patient or hyperphenylalaninemia patient is a blood Phe reduction after 8 hours of more than 30%. However, this has been redefined in 2005. We have rapid responder, moderate responder, or slow responder. It depends on how much is the reduction in the phenylalanine after 8 or 24 hours. And from my experience, we have many BH4 responders in Kuwait. 50% of the patients that I follow has been BH4 responder. Some of them, they even had to stop taking the milk formula that is devoid of phenylalanine, and they have stopped taking the low protein, and they are normally taking normal diet, and their phenylalanine is within the targeted level. And there is a specific website called BioPKU database, which has all the database about the PKU patient. It seems that there is a correlation between BH4 responsiveness and the type of a mutation. About 70% of mutated alleles within the PAH gene are BH4 responsive. So sometimes if you can't do BH4, if you do the mutation analysis and you find this is the specific mutation, the patient is BH4 responsive, you can go ahead and prescribe BH4 for the patient. This is a Spanish study on BH4 responsiveness phenylalanine. We don't only look at phenylalanine drop, we look at how much protein intake, natural protein intake, has increased when the patient is on BH4. And you can see from the bars, the red bar with BH4, the red bar without BH4, the blue bar with BH4. And you can see that some patients had increased their natural protein intake 5 times of what they were taking. For example, if he was only 5 grams of natural protein, which is nothing. Maybe 2 bread of toast is a natural, is a food that contains 5 grams of protein, and the rest of the day he has nothing to eat other than the low protein diet. And this has doubled 5 times, so he could take 25 grams, which is a fortune for these poor children. We come to the second amino acidopathy, which is tyrosinemia type 1, and we screen for tyrosinemia type 1. Tyrosinemia goes through a process of degradation. There are many enzymes involved. In tyrosinemia type 1, we have fumarate acetoacetate deficiency, and this leads to the accumulation of succinyl acetone, which is the toxic part that leads to the damage of the liver and the kidney. And also it interferes with heme analysis and gives you porphyria-like signs and symptoms. It can present as an acute form or a chronic infantile form. And you are all aware of the signs and symptoms of untreated tyrosinemia type 1 patient. And since the introduction of orfadine, or also called an anti-BC, we convert tyrosinemia type 1 to tyrosinemia type 2 because orfadine blocks the enzyme that's known for hydroxyphenyl pyruvate deoxygenase. And the reason for that is that we want to prevent the formation of succinyl acetone, which is the toxic part in tyrosinemia type 1. Previously, patients were treated only with diet, and their survival rate was 29% because either they die from acute liver failure unless they are going for liver transplant. But with the introduction of orfadine, which was started before 2 months of age, before there is any significant damage to the liver, the survival rate was 80%. And this is a study that compares the patient 5 years survival in 1994 compared to 10 years survival. The blue bar tells you the diet alone cases, and the burgundy bar tells you diet and anti-BC, or we call it orfadine nitisinone. And there is a huge difference between the survival rate among the two groups. The second amino acidopathy is the homocystinuria patient, and this involves a transmethylation, transsulfuration part, or a remethylation part. So the classical homocystinuria is a defect in the cystathionine beta synthase deficiency and leads to very elevated amount of homocysteine and high hypermethionemia. Or there is a deficiency in the remethylation part, which involves the copolamine defect, or in the MTHFR, which is the folate-related part of the remethylation cycle. And I'm sure you have seen homocystinuria patient. It affects on the eye, skeleton, vascular, central nervous system. It is a very debilitating disease. However, with the introduction of the medication that's called betaine, which is provides a methyl group that binds to homocysteine to form methionine. So in patients with CBS deficiency, we treat them with pyridoxine because pyridoxine is a cofactor, but patients are tested for pyridoxine responsiveness. And majority of the patients that we deal with in the GCC country are pyridoxine non-responders. But we do put them on pyridoxine just in case that there is a little bit of a push of the activity of the enzyme. We give them the betaine, vitamin B12 and folic acid to move forward in the remethylation cycle, and we give them a low methionine diet. However, in patients with remethylation methylation defect, either in copolamine defect or MTHFR deficiency, we give the betaine, we give the pyridoxine, we give cysteine supplementation because they are deficient in cysteine, and we give them methionine supplementation. Those pictures tells you exactly if this patient has been not diagnosed early and treated, because homocystinuria is a very bad disease. Our recent case that we have diagnosed was a 14-year-old boy who presented with right hemiplegia, and he had a stroke. And when we screened the other siblings, one of his siblings was also affected. Maybe they had a milder disease, that's why they presented in childhood. We don't know yet the mutation of the genes, but they do have a classical homocystinuria. So this is the homocystinuria patient prior to the era of treating them. And the boy on the right side, his name is Jacob from Australia, who was diagnosed in newborn screening program with homocystinuria, and he was treated during the newborn period, and he is leading a beautiful normal life. Enzyme replacement therapy. Gaucher disease type 1 was first to be treated in the 1960s, and it has been an effective way of treating such patients. Comparing 1,028 patients with type A, this is from Gaucher registry, treated with ERT from 2 to 5 years. It prevented progressive manifestation of the disease, and it ameliorated Gaucher disease-associated anemia, thrombocytopenia, organomegaly, bone pain, and bone crisis. And when we come to the figures, this just tell you how it drops spleen volume, it increases platelet count, and reduces liver volume. And this is how ERT has transformed patient with Gaucher disease from patient with massive abdominal enlargement, mainly spleen, to a normal-looking child going to normal school. Also, 33 Gaucher patients treated with ERT, more than 50% of them, after 48 months of treatment, they denied any bone pain, and 11 out of 13 patients reported bone crisis had no recurrence of bone crisis. And bone crisis of Gaucher can be really severe if you compare them to sickle cell anemia patient. Also, enzyme replacement therapy in Gaucher disease has improved the bone mineral density, and when 160 patients with Gaucher disease without enzyme replacement therapy compared to 340 patients on enzyme replacement therapy, those without treatment, they remained at -1 standard deviation below the reference population over time, and it dropped also. And those who were treated improved significantly over time with a Z-score of +1.32 Z-score units per year per treatment.
Sorry, Dr. Nawal, time factor, a few minutes.
Last one is Pompe. I will skip Pompe because Pompe, we have cases. Pompe is a glycogen storage disease, lysosomal storage disorder, leads to the accumulation of glycogen and leads to the destruction of muscles. And with treatment, there has been a significant improvement in the muscle structure and resolution of the destruction. It has improved the cardiomyopathy in patient. And there have been many studies on antenatal diagnosis, and this has been, the patient has been treated at 2 hours of age, and this has proved that it was an effective way of managing Pompe patient. This is the last thing, is the MPS type 6. This is a twin study. Age difference between those two is 3.5 years. The eldest child, she had dysplastic mitral valve with mitral valve incompetence, restricted range of movement. She had corneal clouding, and she had severe scoliosis, and she was booked for ERT. And this is the little boy who was just born and was diagnosed with MPS. This tells you the effect of ERT on joints movement. You can appreciate on the on SIB1 on the left, she had a claw hand, and with movement and physiotherapy, she regained her functionality of her hand compared to the left to the right side with her sibling who did not develop any claw hand. And sorry, this tells you the scoliosis and the skeletal deformity before and after treatment, and the patient was removed from the scheduled rod insertion. And this is the boy. There is a pictus. The ERT does not really completely resolve the bone manifestation, but it ameliorates it and make it less progressive compared to patients who are not on treatment. And most importantly, the left side tells you, if you can see this, the spot, the child who is diagnosed later and treated later. She's very short compared to her sibling, and this is the difference in size between them, and there is 3.5 years difference. So benefits of early therapy on joints, liver, and spleen. There are some limitation on board corneal clouding, cardiac valves, and there are further studies going on of giving an increased dose. This is my last slide. Advancing to meet patients' need. The metabolic drugs are really advancing very fast. It is not important to memorize their names. It is important to understand that you have to have the best outcome. Treatable metabolic disorder should be recognized early enough to start treatment and prevent irreversible damage. And thank you.
Thanks, Dr. Nawal, for this very informative lecture. And really, the drugs for metabolic disorder really change the life of our patient. Now, time for questions.
I would like just to thank Dr. Nawal for her usual excellent presentation, and I am so proud to have a Kuwaiti metabolic/genetic specialist representing from the Gulf countries. In fact, whenever we go abroad, Nawal is there, either with her name in her papers. My question to Nawal, of course, Mujahara is proud to have you, by the way. And Dr. Fahd, I think he's so proud to have Nawal as well with us. My question to Nawal, just to be more practical, we are general pediatricians and you are specialized in metabolic disorders. What are the drugs which is right now available in Kuwait at this moment? If tonight somebody gets sick in Addan, Jahra, KOC, anywhere in Kuwait, are you ready to have all the drugs which you mentioned right now available in Kuwait, yes or no?
KOC, we don't care about KOC because they don't belong to, sorry, I didn't mean we don't care. They can get the medication whenever they want, but Carbaglu, Arginine, and Amonol and Amonabs are available in each single NICU and pediatric ICU. Sometimes we face the fact that medical stores does not want to dispense the medication in each single one of them. So they say if it's in pediatric ICU, we will not put it in ICU. But now it has changed since we have faced many cases that we have to run and get the medication from NICU or from PICU. It is available in each single pediatric ICU. And thanks to Badr Sultan and their, they are following the stock each time. Each time we, use some ampoules, it has to be replaced immediately. And this has made a lot of difference. And I'm sure the residents know this. The residents know that when the medication is available, it makes a hell of a difference in terms of the time-wise in initiating the management. And it made a big difference for the patients as well. So it is available, definitely. The 4 important hyperammonemia medications are available. But enzyme replacement is by patient case, so it's not available for everybody. Which disease?
Other than enzyme replacement for Gaucher disease, according to your experience, what is the efficacy or what is the most effective enzyme replacement therapy? What is given to our patient?
I think Gaucher patients, especially type 1, is the most effective one. For lysosomal storage disorders, Pompe, if you catch them early and treat them early, although the infantile type and they are CRM negative, their response is not that great unless you do immunomodulation, because now the trend is to do immunomodulation before you start the patient on enzyme replacement therapy. For MPS type 6, also it is effective if you catch the patient really early. That's why I emphasize the fact that you should recognize them as early as possible to implement, to make use of this very expensive medication. It costs about 68 to 75,000 per year per patient. But Gaucher has been the most successful type of enzyme replacement therapy since it was started. There is Fabrazyme also for Fabry. I didn't mention all of them. There is for Hunter, Elaprase, and there is for Eldurazyme for patient with MPS type 1. So there are many. And there is also, we've just started MPS 4. And you know, MPS 4, MPS 6, they have normal mentality. So they deserve to be treated and have a good quality of life.